back. This is our wonderful practical C's going on, do this, not that, for physician engagement. And as you already know, that physicians are not engaged by one thing or another, and there are multiple things that physicians do that engage them. And today we have our wonderful Dr. Dean again. He's also an MBA. He spent many years in Vizient Solutions in developing physician workforce solutions, but recently something exciting happened. He is the new, fresh president of QURE Healthcare, QURE, QURE Healthcare. He's also CMO at PRC Healthcare. Welcome, Dr. Dean.
Thank you very much. It's good to be back.
In fact, I'll let you tell us what QURE Healthcare is and what does it do.
Well, QURE is a unique company. We use simulated patient cases to create an engaged educational environment that tests physicians and other providers' knowledge of treatment for many common conditions: heart failure, COPD, diabetes, hypertension, etc., sepsis. And so we're able to create different kinds of cases: age, demographics, race, ethnicity, etc., with a multitude of patient conditions that really simulates what most physicians see in their offices or in their clinical environment. And then we're able to say, okay, here's the case. Here, what would be your working diagnosis? Based on that working diagnosis, what would you do in terms of diagnosis of imaging, labs, etc., physical exam? And then we're able to continue that. Now based on this, what would your diagnosis be? What would your treatment be? Ultimately, how would you even code that case? But at each step, we offer, some examples of options that you could make. You make your choices, and then we provide immediate feedback based on the guidelines for heart failure, for example, or the guidelines for hypertension. Here's what your answer is. Here's what the guidelines would say that you can do. And they're actually kind of fun ways to learn. It's better than just sitting in a lecture and listening to somebody. You're actually doing something. You're making choices. You're using your clinical skill set. And then if there is an answer that you gave that doesn't line up with the guideline, we create hyperlinks to that so you can go right to the guideline or to the peer-reviewed paper at that time and see what the reference is. So this is a great way for physicians to really learn, and the guidelines change so fast these days. Every couple of years it seems like we've got something new coming out about lipids, hypertension, etc. And it's very difficult with all the reading that we are required to do to stay up on all the different guidelines. This is a very engaged way of doing that. And I've been doing these cases for the last few months, and it's interesting that, I thought that the guidelines said this. Well, no, they changed, and now they say this. Ultimately, what we're trying to do is decrease unnecessary practice variation for relatively common conditions. Mm-hmm. And we're trying to improve the quality of the care and decrease the cost of care. So it's really finding a sweet spot, especially in value-based care. Mm-hmm. It's looking to optimize patient outcomes, leverage the team, and really hopefully decrease the cost of care by eliminating unnecessary diagnosis or treatment. So that's in a nutshell what we do. I think the environment provides much more than that than we just talked about.
But doctors don't always follow guidelines either. So how much variations have you seen in doctors about that?
That's a great question, and it's true, and both of us in our practice, we've had many times when we probably haven't followed what a guideline said we should have done, mm-hmm. either because we felt like the patient didn't fall into that guideline, or maybe we were in an environment where we didn't have all the resources that the guideline required, or the patient was in an environment that didn't naturally fit what a guideline said. So as an example, we're working with the emergency room physicians of a large inner city health system in the Midwest. And we were working on sepsis. We developed a simulated case where the patient had a lactate of 2.2, was tachypnic, tachycardic, low-grade fever, and honestly, I couldn't tell what direction the patient was going in. Is the patient resolving? Is the patient progressing, getting worse? And I thought it was a tough case. And after we do these cases, we do them like in 4 cases in a round. After each round, we have a discussion period where we invite all the physicians who participated, we invite the leadership. And so for this particular case, the guidelines said we should have discharged that patient home.
Mm-hmm.
Well, when we looked at the results from all these ED docs at a very good health system, only 20% of them said they would send the patient home.
Mm-hmm.
50% said they would put them in the holding area, and 30% said they would put them in the ICU.
Mm-hmm.
So we had a great disbursement of answers, and 80% of them disagreed with the guidelines.
Mm-hmm.
So now the discussion was why? Why would you answer that way? Well, starting with the ICU, the 30% who said they'd put them in the ICU, they said, I don't know which way this patient's going. In the next 24 hours, they're going to declare themselves as either septic or not.
Mm-hmm.
If they're in the ICU, they're in the absolute right place to be if they go into sepsis. And if they don't, I discharge them home the next day.
Mm-hmm.
An expensive use of an expensive resource, but also in terms of protecting that patient, there's a very good logic there, right?
Yes.
50% that said they would put them in the holding area said, well, I've got an inner city patient population. I'm not sure if they're going to follow up or not. I'm not sure how high the level of patient engagement is with this particular patient. If I send them home, will I ever get them back for a follow-up? And I'm not sure in our health system that I can actually schedule an appointment within 72 hours and get that follow-up scan or get that follow-up lab. So the capabilities of my health system come into my decision-making of what I should do for this patient.
Mm-hmm.
And no matter what the guidelines say, I'm going to do what I think is right for that patient to actually get resolution of what's going on with them.
Mm-hmm.
So it was such a rich discussion. It was very hard to fault any of the logic that was put out there, and it was great for the leadership of the organization to hear this, to think, well, either we need to do a better job with scheduling, we need to do a better job with capacity management,
Mm-hmm.
we need to do a better job on patient follow-up and patient engagement.
Mm-hmm.
But there's always system issues into any decision that we have.
Mm-hmm.
And by asking these questions around this case, we created this fantastic learning environment and discussion that once you're in it, you say, man, that discussion was worth the price of admission right there.
It sounds like this one, particularly because it uncovered like peelings of an onion at the root of decision making of the doctor. Wasn't just the guideline, but what the local resources were. So when this doctor is thinking about a patient versus that doctor is thinking about a patient, they're thinking about 2 very different patients with very different social circumstances, let's say.
You know, and on our last talk, we talked about creating the environment for physician engagement, data, inclusion, respect, communication. And this discussion had all of those things. And you want to talk about an engaged group of physicians because they were able to use a simulated case to really talk about what goes on in real life in their practice every day. And they weren't complaining. They were being realistic and saying, these are the conditions I have to live with. And this is why I'm going to treat that patient that way. And it was a very respectful give and take between the leadership of the organization and the medical staff on what the conditions are in which they treat these patients and what the environment's like and what might be done to improve that. so that if the guidelines really are the way, you could comply with the guidelines, but in an environment that allowed that,
Mm-hmm.
opposed to the current environment they were in, where if they actually sent the patient home, they might never see him again, and God knows what could happen at home. Maybe they are septic and you didn't know it. So I love
Wow.
that
So
discussion.
I can see how exciting and stimulating this can be for a doctor, and
Yeah.
and and and, and how engaging, of course, for a doctor, how rewarding. How did you find the leadership to be, non-physician leadership to be about this?
Well, I think it's a good leadership team. That's why it's one of the top health systems in the Midwest already.
Mm-hmm.
And they understood what the physicians were saying. I don't think the discussion had been put in that context around a particular patient before, which
Mm-hmm.
is what this opportunity lended itself to.
Mm-hmm.
And so I think with that context, they were able to better understand the limitations of what currently is on offer and where the opportunities are for improvement from a system standpoint.
I see.
When I was chief medical officer, we would have medical staff quality discussions. And you can have great discussions around medical staff quality, around particular physician care of a given patient. But almost every time you run into at least one or two system issues. And so we quickly understood that we couldn't just talk about medical staff quality without talking about system quality. So we
Hmm.
started alternating the meetings. One would be medical staff, the next would be system. Because it's really the entire environment. We work within a holistic system.
Mm-hmm.
And unless you're able to address all the variables in that system, you can't really elevate the level of care.
Yes. In fact, I would be surprised by a physician who doesn't want to do something like this. And how is this different than other CME programs that are done like this?
Well, I think one, you're engaged. You actually have to go through, make decisions, see your feedback. And by doing this in multiple cases on the same topic with different presentations and in different rounds, 1, 2, 3, or 4 different rounds over the course of a year,
Mm-hmm.
the learning is iterative. And we actually see a very nice improvement in the mean and the 75th percentile scores from the first round to the fourth round.
Mm-hmm.
So in the first round, for example, for hospitalists, our average is around 58, 59% uh, at the 50th percentile,
Mm-hmm.
and usually around 30 to 35% at the 75th percentile, because it's physicians or high performers, right?
Mm-hmm.
But what we really see after the fourth round is we've elevated both of those scores by about 10% or 15 to 20% of the baseline.
Mm-hmm.
So we really move up the mean score, and we make very nice improvements again on the 75th percentile.
Mm-hmm.
So this repetitive, iterative learning of the same case or the same condition with multiple cases is a very nice way to drive home the learnings. And then we actually see it not only from the scores that physicians do in these tests, but actually with claims data. So in other words, for like heart failure,
Mm-hmm.
we see that the number of patients that were actually on SGLT2 inhibitors went from a baseline of around 100 to over 200 in a few months after doing these cases. So it really does translate into practice with
Mm-hmm.
this kind of learning.
I like what you said earlier, which is none of the doctors were wrong. They all were just coming from their own context, which also is adult learning rather than childlike learning. Those are the guidelines. You better follow them or we'll fail you out of this exam. You don't deserve this CME hour versus, no, I didn't know your context. We didn't know your system had this, or your system did not have these services or whatever resources that were needed to treat the patient. How do you say tell us more about how it plays with value-based care, because that is such a vague animal to kind of like capture.
Well, ultimately, the idea in value-based care is, I mean, we say value, but what we really mean is risk, right?
Mm.
And the risk is financial based on the treatment of a patient or patients, your patient population. The whole reason to have guidelines is there's a body of peer-reviewed literature out there that says if you do this, you have more efficacious treatment and outcomes of patients with that,
Mhm.
right? So, I mean, that's the whole idea behind guidelines. It's not just simply cookbook. It's a summary of the peer-reviewed literature. And we know that if we are able to do that and improve outcomes, we should decrease variation in treatment, both in diagnostic workup, which is really where much of the expensive care comes from, right? Diagnostic imaging, labs, other interventional tests. Now, many times those are required and are appropriate. But there's other times that, given this patient's condition, that really hasn't been shown to be a value. That's low value care. So if we decrease that low value care, we decrease the overall expense. The other thing with all of these tests, there's always a negative to doing tests, right? It
Yes.
could take you down a rabbit hole that all of a sudden you're chasing something that you didn't even know or intended to
Yes.
follow. That in itself can incur high cost without benefit and even harm. So the idea here is we decrease unnecessary variation, we improve the quality of care, and we decrease the cost of care by doing this guideline-based treatment.
Yes. Let me ask you something else, which is your own experience as helping doctors in other places. So, how does that play into what you're doing now?
Well, as we talked about before, I think there's certain conditions that really create optimal physician engagement.
Mm.
Respect, good communication, uh, use of data,
Hmm.
leveraging expertise,
Hmm.
bringing them in into a discussion, understanding the context, providing them with the support that they need to make good decisions. And in these cases, we can bring much of that to life. And
Hmm.
that's what I like about these cases is, again, you're not just sitting there listening to a lecture hoping that
Hmm.
you remember the
Hmm.
things you're supposed to remember.
Hmm.
You're actually involved in doing the work and get immediate feedback from your decisions. So it provides the data, it provides the context of the patient. These discussion episodes after the rounds are very respectful and also do a great job of leveraging the expertise on the phone call with those physicians and leadership, and really understanding the guidelines in the context of the environment that they practice in. So it's a great way to build physician engagement and really get input into your health system where the opportunities for improvement are.
That is such a positive thing to end this talk at, because you're really doing a very noble deed, helping doctors be better at what they do best, which is clinical care, and to feel pride again in the clinical care, and that they're not done learning, but right, like one of the of the physicians who come from osteopathic backgrounds, one of the pledges is I will commit to lifelong learning, and that you are serving that mission of lifelong learning, helping doctors be better at what they do best. This is fantastic. I'm very excited about this thing, because I am really sick of dead end CMEs. It's like, I already know what you're talking about. Why
Right.
are you telling me this kind of stuff?
Well, and as you and I have discussed in the past, one of the great honors, privileges of being in healthcare is being surrounded by people who are lifelong learners.
Yes.
It just moves us all along, and what a joy, what a privilege.
Exciting. How exciting. It's like putting the patient back at the center of this whole talk. Instead of anything else, anybody else, the patient is put at the center of this whole thing and saying, we are dedicated to the patient and serving what's best for the patient. This is fantastic. Thank you, Dr. Dean. And as you're listening, you can see what a fantastic way to engage your physicians, to retain them, and to make them feel you value what they do, as opposed to just looking them as a cog in the machine that's typing money or something like that. So that's where these books' mission, which is enhanced physician engagement, there's nothing better than lifelong learning for a doctor that serves that mission. So thank you. And oh, before we go, if a doctor listens to this and now wants to do this or wants a system to do this, what should they do?
QUREHealthcare.com.
Okay, QURE. Okay, QURE Healthcare.
QURE, that's right.
Okay.
QUREHealthcare.com. Or look me up on LinkedIn, Robert Dean Dio, and happy to talk.
That's right. Thank you very much.
Thank you, sir. Have a great day.